Thanks to everybody for coming today and for listening in. We had to apologies for having to reschedule some weeks ago, but it was unavoidable, and hopefully as many people as possible can make this rescheduled talk. So the talk is in two parts. Professor Beckers is going to start with a general overview of the genetics, the history, the background of pituitary gigantism, and I'll follow on with some specific points as they relate to the treatment, some of the investigations, and as Charlotte said, we encourage you to send as many questions as you have during the text, so we can try and answer them together and be efficient. And so I'm going to hand it over to Professor Beckers now to talk, just to introduce. And we're going to speak about our view of pituitary gigantism from the data that we have at hand, our own data. So, Professor Beckers, you want to say a few words?
No, I think you did very well. So it's a pleasure to speak today with you about pituitary gigantism and to do this with my friend Adrian Daly. So I think we can start with the first presentation.
Okay, Charlotte, if you can start that.
I am Albert Beckers, Université de Liège, CHU de Liège, and during this conference, together with my colleague Adrian Daly, same institution, we will speak about pituitary gigantism, FIPA, AIP, and XLAG. There are several forms of overgrowth and gigantism, but in this lecture, we will speak only about GH-dependent pituitary gigantism. So we will speak about patients who have GH IGF-1 excess due to pituitary adenoma or hyperplasia. How tall is too tall? Gigantism is defined by a height with at least 2 standard deviations above the mean. Today we know several inherited causes of pituitary adenomas. I will say a word about macunal bright, MEN1, Carnet complex, and we will spend most of our time on FIPA and XLAG. The macunal bright syndrome could be a familial disease, but it's a fact today we don't know any case of familial macunal bright. Adrian will say a word about this disease. The MEN1 was described by Dr. Werner in the year 1954, and today we know that more or less 3% of all pituitary adenomas are part of MEN1. There are more than 700 separate mutations in the gene MEN1 that is known since the year 1997. There is no strong phenotype-genotype correlation. It's an autosomal dominant transmission with high penetrance, and patients with MEN1 adenomas are more difficult to treat as compared to sporadic one. MEN4 is a rare disease with MEN1-like phenotype, and it is due to mutations in the CDKN1B gene. It's a very rare cause of gigantism. Carnet complex is a rare and complex disease due to mutation in the protein kinase A regulatory subunit 1 alpha. It was described by Dr. Aidan Carnet in the year 1985, and acromegaly occurs in about 10% of patients with Carnet complex. In the late 90s, there were several cases described with familial acromegaly. In Liège, we had 15 families with pituitary adenomas, but actually there was not only familial acromegaly. So we needed an explanation for this non-MEN1, non-Carnet complex familial form of isolated pituitary adenomas that included not only acromegaly. You can see here this beautiful family from Angers, from my friend Professor Homer, with 2 patients with acromegaly, 1 Cushing's disease and 1 prolactinoma. So we decided to use the acronym FIPA for familial isolated pituitary adenomas. We published the FIPA story in the year 2006, and the same month Dr. Altunen published a paper showing that there was a pituitary adenoma predisposition caused by germline mutations in the AIP gene. So we studied our 73 FIPA families, and we showed that 15% of FIPA had AIP mutations. Furthermore, we showed that AIP mutated patients are younger, 25 years old versus 38, and have bigger tumors, 24 millimeters versus 14, than AIP negative patients. As this was a very important question, we did another study that we published in 2010, where we compared the characteristics of 75 AIP mut to the characteristic of 232 AIP negative acromegalics. And we observed that the patients with the AIP mutations are younger at diagnosis. At the first symptoms, they have bigger tumor, more frequently macroadenoma, more frequently extracellular extension, higher GH level, more frequently prolactin co-secretion, and as a consequence of the age at first symptoms, they are more frequently giant. You can see here typical cases with AIP mutations, 2 young ladies, 19 and 21-year-old, with very big tumors. These cases were published in the year 2001 by Dr. Marily Jafaria and thereafter published with the AIP mutations in 2007. What we know today is that more or less 90% of patients with AIP mutations have hypersecretion of GH plus prolactin or prolactin only. And 80% of patients with AIP mutations are diagnosed before the age of 30. And today we know the at-risk groups for AIP mutations, and these are FIPA, patients with gigantism, sporadic macroadenomas less than 30-year-old, and children with PTSD. But let's come back to this table where we see that 32% of patients with AIP mutations are giant. So 1/3 of 75 is more or less 25 giant. This was a unique opportunity to study gigantism. Therefore, we decided to study gigantism. So we did an international collaborative study and we collected data on more than 200 giants. And what did we learn? We learned that most patients are male, that pituitary tumors are large, that the treatment is difficult, and long-term symptoms burden is high. We collected also data on genetics, and we learned that more or less 1/3 have an AIP mutation, 5% are macunal bright, and only 1% of MEN1 and 1% of Carnet complex. And in 10% we had a surprise. Actually 10% were coming from the NIH, and in a conversation with Dr. Stratakis, we learned that there were 2 instances of duplications of 11 genes on chromosome X. So we decided immediately to collaborate on this problem of duplication. But the problem was that 2 instances is not a lot, 11 genes is a lot. X chromosome not implicated in pituitary tumorigenesis, no gene implicated in overgrowth, and a duplication is not necessarily pathological. And actually the answer came from traveling. After the publication of FIPA, I was invited to give conference and to speak about FIPA and AIP mutations. And I never forgot to mention during my lectures that patients with AIP mutations are frequently young at diagnosis and that they have big tumor or aggressive tumors. And after my conference, I had frequently endocrinologists for adults or pediatricians who came to me saying, I have a young patient with a big tumor. Do you think we should test for AIP mutations? And of course, the answer was always yes. So after 1 month, I received DNA in Liège and we tested for AIP mutations. And in 15 to 20% of the cases, we found an AIP mutations and we could make the testing for the family. And in the other cases, we had no mutations, so we stored the DNA. And after this conversation with Dr. Stratakis, we went back to the DNA. So within 6 weeks, we had a new syndrome that we published in the New England Journal of Medicine and in endocrine-related cancer. And we call this new syndrome X-linked acrogigantism. And what did we find? So in this table, you see patients here with the microduplications and patients without the microduplications, so all giants. The patients with the microduplications are more frequently female patients, 70% versus 24%. They are very young at the onset of rapid growth. The age at diagnosis 3 versus 21. Big tumor in all the cases, but here you can have not only adenoma, but also hyperplasia or both. IGF-1 level very high in the patients with the microduplications. Prolactin co-secretion more frequent, and they are sometimes sporadic, but they can be also familial, whereas in the other group, only sporadic. So here you have the case of the young Belgian girl. She was born small, but you can see how quickly she installed herself at the pole position to become the tallest lady in the world if we do not stop her. Here you can see the MRI aspect, 3 cases with coronal and sagittal views. And you can see that in all 3 cases, the tumors are very large with very big suprasellar extension. The pathological aspect with normal pituitary, hyperplasia, area of transformation, and adenoma. Immunohistochemistry with prolactin and growth hormone, we could expect that, but also high concentration of GHRH receptor. Here is the CGH, and you can see here the length of the duplication in red. In these cases, you can see that the length of the duplication is different from one patient to another, but it always includes these 4 genes. Here you have a nucleus of a young girl with 2 X chromosomes. And 2 genes are identified that are always included in the duplication, RF6 and GPR101. And you can see the normal chromosome with the normal signal and the chromosome with the duplication. So we had always 4 genes included into the duplications, but we wanted to know the culprit, the gene responsible for the disease. These patients are difficult to treat and frequently an operation is needed. So in 2 cases, we had the opportunity to study the expression of the genes, and we showed that GPR101 was expressed 600 times or 1000 times more than in normal pituitary, and we decided that GPR101 was probably the culprit. And it appears that it was true because Dr. Corbonit's group published 2 years later a case with GPR101, which was the only gene included into the duplication. So we have also families with XLAG. So we moved from FIPA to gigantism, and now we are back to FIPA. And you can see here a family from Professor Nalinisha. And you see here the father, the mother, who was acrogigantic. And here a young boy of 6 years old. And here is the son of this lady. And he's only 6 years old, and he's taller than the father. And this patient is, of course, XLAG. So XLAG, a new neuroendocrine pathway. Let's come back to this young girl coming from Belgium. She had elevated GH and prolactin, a large uniform pituitary lesion, a hyperplasia probably, treated with somatostatin analog and cabergoline, but with poor clinical effect, and she was referred for surgery. But before surgery, we studied hormonal levels, and we found high GH, high prolactin, but also high GHRH. In culture, we showed that GHRH receptor antagonists significantly inhibited GH and prolactin secretion. So we have a pediatric patient with gigantism, a pituitary hyperplasia on MRI, an increased circulating GHRH level with GH and prolactin hypersecretion, pituitary GH prolactin hyperplasia and adenoma on histology, high GHRH receptor staining in tumor, no GHRH in tumor on immunohistochemistry. RNA-seq showed no GHRH and massively increased GPR101. GHRH antagonist inhibits prolactin and growth hormone secretion from tumor, so we postulate that there is a hypothalamic involvement. So on the genetic point of view, we have more or less 1/3 of the patients with AIP mutations, 10% who are XLAG, 5% McCune Bright, 1% MEN1, and 1% Carne complex. This case was published earlier and republished in 2016 with the diagnosis of XLAG. This is a FIPA case, and a young boy was diagnosed in utero. And at birth, he had already high GH and prolactin level, and after 3 weeks, pituitary hyperplasia. And this represents the third family with XLAG. So here we are with a new syndrome involving GPR101 duplication, a new gene for FIPA, a new pathway for growth and growth hormone, a new mechanism at pituitary level and maybe at hypothalamic level, new therapeutic perspectives, and currently 25 cases in our group diagnosed, and in total more than 30 cases, close to 40 cases probably today in the world. So this is a new genetic decisional tree for pituitary adenoma and hyperplasia, and you can see here on the right part the gigantism and FIPA, AIP, XLAG, etc. This is the Géant Constantin, one of the tallest giants in the world ever, 2.59 meters. He visited Verviers, the city where I was born, and he died in Mons in 1902, and his skeleton is exposed in the Musée d'Histoire Naturelle in Mons. So in collaboration with Dr. Pinhasi, we had the opportunity to study his DNA and to compare the number of copies of ZIG3 and GPR101. And GPR101 was duplicated and not ZIG3. So this case is an XLAG case. And we published it as a paleogenetic study of ancient DNA suggestive of X-linked acrogigantism. So since then, we have been asked to examine several old skeletons. Here, Lange Anton, 500-year-old in Marburg, but we don't have the result today. But how GPR101 duplication does it induce pituitary disease? To solve this difficult question, I asked to Dr. Hanson and to Dr. Aboud a model mimicking XLAG syndrome. And they organized a mouse model with hyperexpression of GPR101 only at the pituitary level. We see in the transgenic mice higher GH, higher prolactin, higher response of GH to GHRH, higher IGF-1. The mice with the transgenic mice are giant, and you see here the femur, the size of the femur, bigger in the transgenic mice than in the control, with the normal consequences on fat tissue distribution that you can see here, or with the CT scan, and the consequence on glucose metabolism like in human acromegalic patients. But absolutely no impact on the pathology of the pituitary, and absolutely no tumor development as we could have expected. So in the mouse with pituitary GPR101 overexpression, GPR101 drives GH and prolactin secretion. The overexpression of GPR101 does not increase proliferation. In XLAG patients, high GHRH level and high GHRH receptor in the pituitary. The duplication of GPR101 is also present at the hypothalamic level and may be responsible of the high GHRH level, which in turn induces proliferation at the pituitary level. And here is my staff. I think.
Part 2 of this talk, I'm going to speak about the management of pituitary gigantism and some of the challenges that may be encountered. I have no disclosures. Professor Beckers has outlined some of the genetic forms of pituitary gigantism, and I'm going to deal with some factors that cut across these different specific forms and affect pituitary gigantism management in general. Pituitary gigantism is caused by a somatotropinoma in almost all cases. So just like acromegaly, somatotropinomas in pituitary gigantism should be managed according to the management guidelines, right? Well, there are certain aspects of pituitary gigantism that add some additional factors that we need to take into consideration. The Endocrine Society guidelines from 2014 don't highlight any specific circumstances that need to be taken into consideration with gigantism, and it should be managed with the same approach as adult acromegaly. I think since then, since the 2014 guidelines, there are a number of aspects which have come to light that show that pituitary gigantism occupies a particular niche of severe acromegaly. Acromegaly exists as a spectrum of disease from less to more severe, and pituitary gigantism is the most severe form of acromegaly. It has specific characteristics that differentiate it from general adult onset acromegaly, as you can see in this slide, that compares a series of 208 patients with gigantism with more than 3,000 patients from the Liège Acromegaly Survey database. In terms of sex, in terms of age at diagnosis and first symptoms, in terms of maximum tumor diameter, hormonal secretion, and underlying genetic causes, pituitary gigantism represents a very severe niche of the acromegaly continuum. One simple factor that differentiates pituitary gigantism from adult acromegaly is that of final height. Adult acromegaly patients have completed their growth, whereas those who have disease onset in childhood and adolescence, they have the risk of developing a very severely increased final height, which can have lifelong consequences. So that's one of the major factors that we have to take into consideration, and that we'll deal with in the coming slides, showing why this is specifically a major risk factor in these young patients. So what are the key treatment challenges in pituitary gigantism? For simplicity's sake, I've summarized these into 4 main topics: the young age and onset, the relatively large and aggressive tumors, the high levels of hormonal hypersecretion, and also the relative resistance to certain types of therapy. And these 4 topics cut across pretty much all of the subtypes of pituitary gigantism, irrespective of the genetic causes. So one of the main problems associated with pituitary gigantism control is the long delay from the onset of rapid growth until the diagnosis of the pituitary tumor. A little over 5 years on average in this group of 208 patients with gigantism is much shorter in girls than in boys. There's probably a complex set of factors there that includes societal factors, being more tolerant of increased height in boys, also the earlier onset of the pubertal growth spurt in girls, and perhaps greater access to healthcare during the teenage years may play a role in this difference. What else delays diagnosis and the instigation of effective treatment? Well, pituitary gigantism exists as part of a large network of disorders of growth that lead to tall stature. These are rare conditions, some of them pathological, some of them physiological. And in order to get to the diagnosis of growth hormone excess, a number of these have to be taken into consideration and discarded, which can increase the time required for a diagnosis to be made. But the story doesn't stop there. Once the diagnosis has been made, even of pituitary gigantism with established GH and IGF-1 hypersecretion, there's more time required for referral for imaging studies and then referral onwards to treatment by neurosurgeons and endocrinologists. So this adds to the time between the onset of the overgrowth to the diagnosis and then to the instigation of effective therapy. The problem, unfortunately, is not solved by patients being referred for treatment. After they arrive at the endocrinologist and neurosurgeon, the instigation of initial therapies has relatively low efficacy in terms of control, and multimodal therapy is the rule. So this is a situation that requires a lot of time, a multidisciplinary team involving various hospitals, and quite a lot of time of follow-up and judgment of what the next treatment step is going to be. So this is a complicated treatment journey for the patients, and is one that is often difficult to optimize. So all of those practical factors combine to delay from the age at first symptoms, or even the earlier age at first onset of rapid growth, to the age of diagnosis, and to the age at which GH and IGF-1 is controlled. So these factors together mean that for patients that are diagnosed in or around the onset of puberty, control may not be achieved until puberty has occurred, and this is a significant challenge in maintaining a final height that is within normal or acceptable ranges. And as an illustration of this, in patients who are diagnosed before or the age of 20, so during their teenage years or after their teenage years, you can see that patients who are diagnosed later have increased burdens of skin disorders, joint disorders, cardiovascular disorders, and facial changes as compared to those who are diagnosed during their teenage years. So delayed diagnosis seems to have a negative outcome on the burden of signs and symptoms when patients finally are diagnosed. And even at last follow-up, patients, even though they've been diagnosed and have been treated, there's still a momentum of the effects of long-term GH and IGF-1 hypersecretion. And you can see the onset of new diabetes, new sleep apnea, and a worsening of existing joint disorders, headache, etc., which while many patients will improve, you see that almost on balance, the sum of new and worsening symptoms almost equals that of the improvement. So there's a significant symptom burden in these patients on a long-term basis. And given that they're young when they start, this is a lifelong issue and something that we need to be aware of. So in the end, only a minority of patients will have their pituitary adenoma diagnosed and controlled by the end of adolescence. And this has a knock-on effect in final height, as those who have early control have a lower final height than those who have later control. That seems obvious, but it is something that exists currently as a problem that requires optimization. As we saw earlier, patients with pituitary gigantism almost have a known germline genetic cause, the most common of these being AIP mutations, then XLAG, and then in about 5% McCune-Albright syndrome. As you see here, AIP mutations are the predominant cause. Well, AIP mutation-related pituitary adenomas and gigantism really exemplify the treatment challenges that we face. As compared with AIP wild type, AIP mutated somatotropinomas have a much younger age at first symptoms, and also a much younger age at diagnosis. There's about a 20-year age gap between the two. These tumors are also much larger than AIP wild-type somatotropinomas. You can see here a much greater proportion of those that are 20 millimeters and above. And this is also statistically significant. And how does that look in practice? Well, here are two large, aggressive, extensive, invasive pituitary adenomas in two cousins from a FIPA family with an R304X AIP mutation, which is the most common AIP mutation. This exemplifies the type of picture that one can get a presentation with an aggressive pituitary adenoma related to AIP. And here's another tumor, again large, invasive, extensive in a young male also with a low AIP staining due to loss of heterozygosity for AIP in the tumor. Also, AIP tumors are highly secretory. They have a higher level of growth hormone secretion than AIP wild-type somatotropinomas. These are data from the London group of Professor Corbin. It's also confirming this is the young age at onset, about half of patients between the age of 10 and 19. And again, these are confirming that these are large tumors, almost all macroadenomas when they're diagnosed. But in addition to being large, extensive, and occurring at a young age, these tumors, due to AIP mutations, are also less responsive to first-generation somatostatin analogs. They have smaller decreases in both growth hormone and IGF-1 than in control acromegaly. So what to do with somatostatin analog resistance? Well, the SST2 based compounds octreotide and lanreotide are the most frequently used. Here's a case in which we were able to take an alternative approach. It was a patient, a young female with incipient gigantism who had initially a prolactin hypersecreting adenoma diagnosed, who had a large expansion of the tumor. And following surgery, there was a significant remnant left, which was active, which was non-responsive to octreotide, and the patient was trialed on pasireotide LAR and underwent quite a significant shrinkage of their adenoma over time and control of their growth hormone hypersecretion. And here's a second case in a patient with an AIP mutation from a FIPA family who, following surgery and octreotide for many, many years, had active disease. You can see the IGF-1 normal range here in gray below. They were never controlled. There was a person who had tumor expansion on pegvisomant, and we trialed pasireotide and had an excellent response to that. You can see here the IGF-1 rapidly came under control. There was concomitant diabetes, which was managed with multiple medications to the extent that the patient became growth hormone deficient and pasireotide was withdrawn. This patient has remained off pasireotide for nearly 4 years now and is currently well controlled, and their diabetes also resolved after the withdrawal of pasireotide. So it was a good option. One of the key factors explaining this phenomenon is probably related to the levels of somatostatin receptors. And this is a control octreotide responsive tumor with good levels of SST2. This is the tumor from the first patient I showed you who was octreotide non-responsive, and you can see that she has absent SST2 staining but has present staining for SST3 and SST5, which may underline the explanation as to why they responded to pasireotide. Some patients with AIP mutations respond to pasireotide, some don't, so it's not a universal panacea, but it's certainly something worth considering in some cases. So that's the status with AIP mutation: highly secreting, young onset, aggressive phenotype with an impaired therapeutic response. So how does AIP lead to this aggressive phenotype? There are a number of theories as to how this occurs. This is one potential mechanism that we reported recently, that in AIP deficient tumors, due to mutations and loss of heterozygosity, you get increased levels of microRNA miR34A, which specifically targets one of the components of the G protein coupled to SST2, which in turn leads to increased levels of cyclic AMP and decreases the responsiveness of the cell to octreotide. So this may be one of the, among the many mechanisms coupled to AIP that could explain this phenotype. Moving on to XLAG. As we've seen earlier, that's the second most frequent cause, known cause of pituitary gigantism. It's a particularly young onset form of the disease, and many of the tallest people in history have had an XLAG-like disease process beginning in very early infancy. You can see here is the typical patient who began born as a sporadic female with no family history, who went from below the 3rd centile for weight and for height over the 97th centile for height and weight during a very short period of time, the first couple of years of life. It's another typical case. Again, a young patient who was first seen at the age of 32 months, but had been growing since early in the first year of life. At about 11 months, they had large hands and feet, and also widely spaced teeth, which is a sort of an acromegaly-like presentation that's not typically thought of as one seen in children. So apart from the young age at onset, these patients these are small children, aged about 3, they have large pituitary adenomas, some of them quite extensive, as you can see here. When not actively treated, XLAG is associated with continued tumor growth and continued excessive increases in height over childhood. This is a case who was unfortunately not possible to treat until they presented at the age of about 10, 11 years old, with a very large pituitary adenoma. You can see here a very excessive growth. So this is not a self-limiting disease in any way. What happens to growth during treatment? Well, I have a series of growth charts of different XLAG patients. Here's a patient who you can see the gradual increase in height over the first year of life, the introduction of dopamine agonists, which did really nothing for growth, followed by a surgery, which was a very extensive surgery, a resection of virtually all of the anterior pituitary, which led to a very good control of growth, but hypopituitarism, which by the age of 7 or 8, the patient was falling off their growth line and required growth hormone supplementation to achieve a normal growth over their teenage years. Another case here, which is probably more representative of the multimodal therapy that's often tried, surgery, introduction of somatostatin analogs, which didn't work, and dopamine agonists, which didn't help. In this case, the introduction of pegvisomant was associated with a change in his growth velocity, and over time he has approximated to the normal growth curves. Here's a further case of this multimodal therapy, a good effective surgery where there's a very large debulking of the tumor, which leads to big decreases in growth hormone and prolactin. But unfortunately, even small remnants in patients with XLAG are capable of producing large amounts of growth hormone and keeping levels of IGF-1 elevated. This is a case where it required combination somatostatin analogs, dopamine agonists, which didn't work until the introduction of pegvisomant. And here's a similar case where there's an initial large decrease following surgery in terms of growth hormone, but a residual tumor was able to maintain levels of IGF-1 above the normal range we see here, leading to overgrowth during childhood, and this required the introduction of pegvisomant. And unlike in AIP, this resistance to first-generation somatostatin analogs is not related to low levels of SST2. You can see here very good levels of SST2 in patients with XLAG, also SST5. So this is a different pathway of resistance, and anecdotally we don't have good evidence that pasireotide is effective in XLAG. We need to do obviously more studies on that. The pathway for disease in XLAG is related to GPR101 overexpression, and recently we're able to show that there are two parallel pathways activated by GPR101 excess in mice and also in humans with XLAG. You can see a protein kinase A excess and also a protein kinase C pathway overactivation, which leads to overgrowth in mice in terms of bone and body length. And they have an increased level of protein kinase C activation, as phosphorylation, in their pituitary as compared with wild type. And looking in humans, here's the case in wild type mice. There's very little activity in the protein kinase C pathway, an AIP related non-XLAG tumor. Then you compare that with the transgenic mice and also the XLAG human tumors, where there's high levels of this protein kinase C pathway activation, which may explain the very high levels of GH excess that we see. So there's McCune-Albright syndrome, the third of the three main factors genetically associated with pituitary gigantism. You can see it's about 5% of giants in our series. It was reported back in the 1930s by McCune and Bruch and also the Fuller-Albright's group. We know that it's a typical syndrome of cafe-au-lait macules, these irregular cafe-au-lait macules, polyostotic fibrous dysplasia, and endocrinopathies, which about 20 to 30% of patients have GH hypersecretion. Most frequently are pituitary adenomas, but they also have hyperplasia. And patients with McCune-Albright syndrome, there's a particular interaction between the bone and growth hormone hypersecretion that can worsen outcomes. So in McCune-Albright syndrome, acromegaly is seen in about 20 to 30% of cases. It's usually diagnosed at a younger age than sporadic acromegaly, and fibrous dysplasia of the skull base is the rule. This can interfere with diagnosing some of the typical facial features of GH excess, and of course one must recognize that patients with precocious puberty due to McCune-Albright syndrome may have growth acceleration that's not related to GH excess. When you have the concomitant effect of GH excess and also precocious puberty, this can confuse and delay the diagnosis. There really should be an extremely high index of clinical suspicion for GH excess in the setting of McCune-Albright syndrome. McCune-Albright syndrome and acromegaly, there's at least a third are diagnosed under the age of 16, and many patients probably have their disease onset in childhood. They're mainly macroadenomas. Hyperprolactinemia is very frequent, and control only occurs in about 50%. This is from the series of Paris from Professor Chanson and also from the Collins group at the NIH. Here's a case of McCune-Albright syndrome and gigantism. You see this early onset with severe overgrowth in terms of height and weight. This is a person who had significant polyostotic fibrous dysplasia affecting the craniofacial region. And here was the pituitary adenoma in this patient. It was quite an extensive adenoma, one that was associated also with a diffuse somatotrope hyperplasia. Here's the craniofacial fibrous dysplasia. We're talking about centimeters of bone here in this case, which can significantly restrict surgical access. Due to the complicated surgical control in McCune-Albright syndrome, medical therapy plays a very important role. Somatostatin analogs plus or minus dopamine agonists can control about a third of cases. And the current thinking from the larger groups suggests that the addition of pegvisomant should be considered if 3 to 6 months of lack of control has been obtained with long-acting somatostatin analogs. So to summarize, so in terms of age at onset, there's a genotype-phenotype relationship in pituitary gigantism, with patients with XLAG having much earlier disease onset and age at diagnosis. And there's a latency period that's quite short in XLAG, probably due to its very severe phenotype in young childhood. AIP has a relatively shorter latency period than genetically negative cases. Tumors universally in pituitary gigantism are large, generally macroadenomas. They're extensive, and they have an impaired response to therapy. And also hormone levels are high, particularly in XLAG, And one of the things to note is that prolactin co-secretion is an important feature of both XLAG and McCune-Albright syndrome, and a third of patients with AIP mutations are also have hyperprolactinemia. We recall that hyperprolactinemia can worsen hypogonadism, and that can play a role in delaying the closure of growth plates. So it's something to control both hyperprolactinemia and GH and IGF-1 as one of our goals of treatment. As we said before, the tallest patients, the disease begins early, so the Z-score for height in XLAG is often higher than those with AIP, but we should note that genetically negative cases also have quite a severe disease, and this represents one of our areas for future research to try and work out what is the causative genetic change or molecular change in these cases. So here are the management challenges. As I've said, the age of onset is young, in the early childhood to the teens typically. Tumor sizes these are large and invasive tumors which may be associated with hyperplasia. These tumors are also highly secretory of both growth hormone and prolactin, leading to high IGF-1 levels and hyperprolactinemia that's very common, and they can also be resistant to first generation somatostatin analogs. So pegvisomant co-treatment is often required in order to attain GH and IGF-1 control. And in patients with pituitary gigantism, genetic investigation should be at the forefront of our management, as nearly 50% of patients have a known underlying genetic cause which can have clinical relevance. So thank you for your attention. Thank you to Endo-ERN for giving us this opportunity to speak on pituitary gigantism, and many thanks to our great collaborators around the world, including Gianpaolo Trevelyan, Konstantin Stratakis, and others. Thanks to our team at the CHU in Liège, and we're always available for discussion of interesting cases should they.
Presentations. Do you have any hypothesis on why there are several XLAG cases with pituitary hyperplasia rather than a tumor?
Okay.
Yes, okay. So if I understand well the questions, because there was some cut. The question is why there is a hyperplasia in XLAG rather than a tumor. This was the question. So it's probably due to the fact that in XLAG patients, the mechanism producing the hypersecretion of GH is probably double, situated at the pituitary level, but also at the hypothalamic level. So as shown with the mouse model, when we have GPR101 duplication or hyperexpression at the pituitary level, there is like a turbo at the cell secreting GH. So there is hypersecretion of GH, but there is no hyperplasia. And to have the hyperplasia, it's probable, the hypothesis that we do now is that to have the hyperplasia is that you need to have a hypersecretion of GHRH that you have in the human model, if I can speak like that. In the XLAG patients, you have hypersecretion of GHRH, and the GHRH is produced. We know that for a long time now that the hypersecretion of GHRH, for example, by neuroendocrine tumor with ectopic hypersecretion of GHRH, does produce a pituitary hyperplasia, and even after a long-term secretion, formation of adenomas.
Yeah, so there's just to add on that, you know, you see in XLAG you see a combination of you can occasionally get isolated hyperplasia, but I guess it depends really on the duration of the disease and the particular situation in the tumor of the patient. It could hypothetically be possible for a family to have only hyperplasia, but I think really the fact that there are, you know, very small adenomas can be found within hyperplasia in XLAG means that there probably is an adenoma or an adenomatous process there that's going to occur sooner rather than later, and almost all of them are adenomas. So are there any other questions?
Well, from the same person, there is a final question. Do you think the definition of FIPA should perhaps be updated to include these instances of hyperplasia hyperplasia, I think it should be hyperplasia.
Yeah, theoretically, I think it's going to be very, it's going to be, you know, individual cases or individual people. I think that perhaps among the larger group, there may be other families where there may be a single person with gigantism and some other tumor that are not AIP related or that are not XLAG related. Those ones still have to be discovered, but hyperplasia tends to be one of those signatures that underlies a probable germline genetic component. Most of the causes of pituitary adenomas in the genetic setting have more frequent hyperplasia. So I think it's, you know, technically, I think one would, you know, classify a person with hyperplasia. You could classify them under the FIPA definition, working definition, but I think we need to have more cases before we do a revision of that definition officially, I suppose.
Okay, thank you very much. I don't see any other questions.
If there aren't any other questions, people can always get in touch. You know, either through we can set something up through the Endo-ERN with regard to you know, patient conferences. There are always that possibility of doing those things. It's more difficult to do in some countries due to patient privacy, but I know it's one of the real interests of Endo-ERN. And we're happy to participate in those type of conversations. The other thing to really highlight is that, you know, the suspicion really we have to highlight to among pediatricians, generalists, etc., that when the suspicion of growth hormone excess is there, is really to act on it, because there's a long delay between the first onset of growth and patients becoming controlled. And that's something that is really up to physicians and medical systems to improve. So if you suspect GH excess, I think it's probably, if you think about it, then it's probably worth testing for it, because by the time all of the diagnostics, referrals, and whatever go through, it can take some time. And there have been some kind of tragic cases in the press and others of people who had a delayed diagnosis, which it didn't have to be that way. Given that while therapy is not very straightforward in gigantism, the main thing in pituitary gigantism is to get the diagnosis as quickly as possible and to get patients onto the proper mix of therapy. So I think that, you know, if we suspect a little bit more, it's still very rare, but if we suspect a little bit more, we might improve those outcomes in those patients.
Absolutely.
Okay, well, I think we've covered all questions and your final remarks. Thank you very much. So, well, thank you again for your valuable and excellent talks, and everybody for joining today's Endo-ERN webinar. And again, it will be available at our website within a couple of days. You will get a notification about that. And well, then we will close the webinar, and wishing you all a very good day.
Thank you.
Thank you very much. Bye now.
Bye-bye.